Dental implants are the gold standard for replacing missing teeth, offering function stability and long-term success when planned and executed correctly. This session breaks down implant biology components, surgical principles, and exam-relevant concepts in a concise, clinician-friendly format. The primary purpose of a dental implant is to replace missing teeth by anchoring a prosthetic crown directly into bone. Modern implants mimic natural tooth roots and integrate biologically through osseointegration. Not every patient is an ideal implant candidate. Absolute and relative contraindications include uncontrolled diabetes and immunocompromised conditions. Insufficient bone volume or height can preclude implant placement. Bisphosphonate therapy increases risk of medication-related osteonecrosis of the jaw and is a concern. Bruxism or heavy clenching and grinding can compromise implant success. Smoking is a relative contraindication that negatively affects healing. History of head and neck radiation can limit implant candidacy. Cleft palate patients require special consideration and planning before implants. Adolescents should usually wait until jaw growth completion around 20 to 24 years before implant placement. Old age alone is not a contraindication to implant therapy. Many implant contraindications overlap with extraction contraindications. Subperiosteal implants are placed on top of bone under the periostem and do not osseointegrate. Transosseous implants pass completely through the mandible and are rarely used due to complexity. Endosteal implants placed into bone are the modern standard, with root form designs being most common. An endosteal implant assembly includes the implant body, the abutment screw, and the implant crown. Surgical principles include sequential osteotomy using sharp drills and copious irrigation to prevent thermal damage. One-piece implants have implant and abutment fused, offering limited angulation correction. Two-piece implants separate implant body and abutment, allowing angulation correction and better prosthetic control. Anti-rotation features like internal and external hex prevent abutment movement in two-piece systems. Screw-retained crowns are retrievable, avoid cement complications, and require less vertical space. Cement-retained crowns offer superior aesthetics but can be non-retrievable and risk peri-implantitis from excess cement. Osseointegration is direct bone implant contact and is required for long-term stability. Fibrous integration indicates mobility and is a sign of implant failure. Primary stability is mechanical immediately after placement, while secondary stability develops biologically over weeks. Critical safety distances include at least 1.5 millimeters from adjacent teeth and 2 millimeters from the inferior alveolar nerve. Maintain 3 millimeters between implants and 1 millimeter buccal and lingual bone thickness for predictable outcomes. One-stage surgery leaves a healing abutment exposed and involves a single operation. Two-stage surgery buries the implant under soft tissue and is used when primary stability is poor or grafting is required. Open tray impressions are the most accurate, while closed tray techniques are simpler. After extraction, atraumatic removal bone graft placement and collagen membrane help preserve the socket. Implants lack a periodontal ligament, so gingival fibers run parallel and soft tissue attaches differently than natural teeth. Criteria for success include immobility, absence of radiolucency, minimal bone loss, and no pain or infection. Thermal damage above 47 degrees Celsius compromises osseointegration. Dental implant success results from precise planning, biologic understanding, surgical discipline, and prosthetic accuracy. Mastering these fundamentals impacts implant longevity and patient outcomes.